All right, that was truly a very exciting session. And now is the time, ladies and gentlemen. We come to the last session for this fabulous second day. But before I do that, I must thank once again to the Holy Trinity. In fact, I would call them the Healthy Trinity, which is MHFI, AIMS, and Rahat Charitable Trust. All three culminating together to unlock the power of being one, healing self and healing others. That is what it is all about. With that being said, ladies and gentlemen, I hope you are ready. All the audience members, please be very, very aware. Listen carefully, because whatever questions you need to put, you please put it in the box, the chat box that you see. Place the questions. They will come to the person who is going to lead the session, and then it will be placed towards the speaker, and it will be a good 15 to 20 minutes of Q&A session, which will be very interesting after this this very much awaited presentation, that I would say. And a big thank you to our sponsors, which is a silver sponsor, Lupin Limited. So all in all, a big thank you to all our sponsors, but this particular session has been sponsored by Lupin Limited. So a big thank you to you. With that being said, all the way from Canada. So I should say welcome, eh? So all the way from Canada, we have Professor Alan Fung, co-chair section on religion, spirituality and psychiatry, World Psychiatric Association. And the topic that he's going to enlighten us about is teaching religious and spiritual competencies to medical students and residents, physicians, the why, what, when, and how. Now, these are very important questions, and to lead us into this session, we have none other than the right culmination of beauty and brains together. We have Ms. Punita Puriji, founder and director of Entelechi Wellness Private Limited. I hope I have pronounced that correctly. If not, my apologies. Ms. Puri is a chartered accountant with 17 years of experience in diverse finance leadership roles with corporates, and her inner journey initiated in 2012, which led her to connecting to a spiritual self and the start of a transformational journey. So now, with that being said, ladies and gentlemen, it's over to you, ma'am, and welcome, Professor, once again.
Thank you so much. And I would like to begin by saying good evening to all, and good morning and good afternoon, because I think people from different parts of the world are there. And thanking the Mental Health Foundation for such an amazing event, because I've been listening to various sessions and they have been so enriching. It is so nice to see spirituality, yoga, and meditation, which is coming now and being recognized by the medical health professionals. And it is being taken as a practice and encouraged as a practice as well. If we look at few years back, even for me, I would say 5 years or 8 years, these words like spirituality and all was parked for 60 plus age. You know, we'll do all these practices when we will retire and get into meditation. Right now, we need to focus on work and our future. Little did I know that I would get into this much earlier in my life. And it has been a huge transformation for me inside. So I feel that there's a big part of us within us, which we do not acknowledge and recognize, which is the mind, our thoughts and our emotions, which play a very big role in the physical self. And I think that is where the session today will be very enriching to hear Dr. Alan Fung and his journey, because it has so much vast experience in the area of spirituality. So I will begin by introducing him. Professor Alan Fung is the medical director of Mount Sinai Hospital Wellness Center, University of Toronto, Faculty of Medicine in Toronto, Ontario, Canada. He's also a research professor at Tyndale University in Toronto. He currently serves as the co-chair of World Psychiatric Association section on religion, spirituality, and psychiatry, the vice chair of the American Psychiatric Association, Caucus on spirituality, religion, and psychiatry, as well as the advisory board member of the Conference on Medicine and Religion. He's also a co-editor of the book Ethical Considerations at the Intersection of Psychiatry and Religion by the Oxford University Press. He has strong clinical and academic interests in the cultural and spiritual religious dimensions of mental health care. mental health promotion, as well as health professional education. We look forward to hearing his session now. And for any question and answers, please leave them in the chat box and we will take them up at the end of the session. Thank you. So over to you, Professor Alan Fung.
Thank you very much, Ms. Puri. It's a great pleasure to be here with all of you. Again, good evening, good afternoon, good morning, depending on where you are in the world. So I'm just going to share my slides. So I hope all of you can see the slides. The topic that I've originally set for the talk is teaching religious and spiritual competencies to medical students and resident physicians, the why, what, when, and how. Now, the reason why I said originally is when Dr. F.D. Sharma, who had kindly invited me to be a speaker at this very important summit, so my great thank you to him and to all the organizers. I readily accept his invitation. After all, my colleagues and I actually just recently published this article. It's called Teaching Spiritual and Religious Competencies to Psychiatry Residents, a scoping and systematic review in the journal Academic Medicine. So it's now available online, waiting for final editing. So I thought, no problem, I can actually share some insights on this topic. But when I learned more about the nature of this conference, I understood that the theme of today's conference is focusing on the role of spirituality as a means to enhance mental well-being in medical students and healthcare professionals. So the talk that I'll be doing today is quite different than what I had originally planned, but hopefully it will be more relevant to what the summit, the conference is about, which is how can we use spirituality to help healthcare professionals to regain their humanities. Indeed, from the conference website, I was shocked, but also not surprised by some of the evidence shared on the conference website. And I'm sure you're very familiar with this data, but I want to reemphasize these. So approximately 80% of doctors, especially at the earliest stages of the academic career, face the risk of burnout. 30% of Indian doctors and physicians go through depression, and 17% have experienced thoughts about ending their life. As you listen to my sharing, I would like you to keep in mind these data, and I'm also keeping in mind this data as I'm speaking to you today. And hopefully the discussion today will also be relevant to what the National Medical Commission had launched recently, which is the proposed Attitude, Ethics, and Communication module for undergraduate medical education in India. Again, I thank all the organizers of this conference for the opportunity to share with you my experience. The past 2 years have been especially stressful time for everyone working in the healthcare professions. Of course, for everyone in general, with the COVID-19 situation. And burnout, distress, especially prevalent throughout the health professions. And different organizations have actually issued or published different guidelines or resources for how can we help to enhance the well-being and reduce distress for healthcare professionals. For example, the British Psychological Society had published a guide on how to address the psychological needs of healthcare staff as a result of the coronavirus pandemic. In Canada, we also had similar agencies publishing different guidelines. So I have no financial disclosures. And as Ms. Puri had mentioned, I'm the current co-chair of the WPA section on religion, spirituality, and psychiatry, vice chair of the APA Caucus on spirituality, religion, and psychiatry, and an advisory board member of the Conference on Medicine and Religion in the United States. So I would like to go right in to talk about different studies looking at the role of spirituality and burnout among medical students and trainees. So for the first part of my talk, I'll be focusing on these various studies looking at this specific aspect of spirituality in the medical profession. And later on, I'll go back to what I originally intended to talk about, which is, in general, how do we teach spiritual and religious competencies to medical professions in general. So this particular study was done in Massachusetts, in Northeast United States, by Amy Wechos and Milan Rangoff. And it addresses the very important topic of spirituality, burnout, coping, distress. And before I go into the details of the study, I want to show you some of the information they talk about in this article about burnout and physician distress. Now, so far in the conference, I understand that you have already heard many distinguished speakers, including yesterday from Professor Dinesh Bugra about burnout in medical professionals and students. So I'm not going to spend too much time focusing on this topic, but just want to briefly mention when we talk about burnout, which was a term coined in the 1970s, it consists of three major domains. So one is emotional exhaustion, two is depersonalization, three would be feelings of decreased personal accomplishment. And these three domains and burnout overall have been associated with medical errors among family medicine, internal medicine, and pediatric residents, as well as among practicing surgeons. So these are some of the studies that have actually reported these issues. Indeed, it's not just in resident physicians and practicing staff physicians, but also in medical students. So various studies published around 15 years ago had talked about the serious consequences in medical students from burnout, including poorer mental health, depression, increased suicidal ideation, thoughts of dropping out of medical school, and decreased quality of life. Indeed, it's also been reported that medical students could have decreased empathy for patients, which would affect patient care. As well, people are prone to having more unprofessional behaviors, as well as decreased altruism. So it's a big issue, not just in practicing physicians, but also in our youngest trainees in the medical profession. So going back to this study, they were using various scales, including the Daily Spiritual Experiences Scale, a burnout measure short version, the Functional Assessment of Chronic Illness Therapy Spiritual Wellbeing Non-Illness Scale, Hospital Anxiety and Depression Scale, Brief Hope Scale, and Satisfaction with Life Scale to measure various parts. And just going back to the abstract, you will see that they aim at looking at how spirituality, burnout, psychological distress, coping, and general happiness are related. by using various analyses, including correlation analysis, as well as more sophisticated modeling. As you will see from this table, these different variables are actually quite strongly correlated, either positively or negatively, as what one would expect. For example, you see that the anxiety and depression scores would actually correlate positively. You see the correlation is around 0.7 with burnout. Not surprisingly, that's what we would expect. Anxiety, depression, burnout, they all run together. And also, you will see that things like life satisfaction or coping would be negatively correlated with burnout. And you will see that these are actually pretty strong correlation. And you will also see that things like the spirituality is also negatively. So the stronger one is in terms of spirituality, the less burnout one would be. So that would be shown by the daily spiritual experiences scale, which is negatively correlated with burnout, as well as the anxiety, depression scores. And in this more sophisticated regression modeling, they were trying to look at what are significant predictors for the burnout. And as you will see, anxiety, depression, these are all included. So the main findings from this study was that students who endorse statements leading to higher scores on the standardized measures of spirituality, they are less likely to endorse items correlated with high burnout or depression, which is what one would hope, if we believe that spirituality would be protective of our well-being. So the authors have suggested that strong spiritual resources and daily spiritual experiences are associated with higher life satisfaction and lower psychological distress and burnout. And indeed, the presence of high spirituality may be protective against burnout in medical students. Now, so that was a study done in the United States around 10 years ago. I want to show you next two studies from India. So this study is called Spiritual Health and Coping Skills Among First-Year Medical Students. It was done in Göttingen. And so you'll see that the study was done in 2015 in the Government Medical College in Göttingen. And they had done the study on 138 first-year medical students. And let me show you some of the results. So again, they were trying to look at the role of spirituality and also coping. So for spirituality, they use something called the spiritual assessment scale. So spiritual health assessment scale, which was actually something devised in India, and also something called a brief cope scale to measure coping. You will see here that for the spirituality, they have three sub sections under the spiritual health. So self-development, self-actualization, and self-realization. So these three subdomains and the total spiritual health, interestingly, they were actually all higher among females in the study. Not only that, you would actually see that many of the females students in the study, 95 to 100%, they actually achieve good status in terms of spiritual health. And I've listed above how they actually define the good versus fair versus poor spiritual health. Also, when they use the brief COPE scale to measure coping, they also saw that the female students, generally speaking, were actually coping better than the males. And these were the different areas measured in the COPE scale. Things like adaptive coping, active coping, seeking emotional support, reframing, and things like that. And there are also some negative coping strategies measured there: substance use, self-distraction, self-blame, things like that. And also, some more positive, coping strategies like acceptance, turning to religion, etc. So the authors basically reported that overall, only 30% of the students had good spiritual health, although the spiritual health scores among female students were higher than those of the males. And also, female students show significantly higher adaptive coping and religious coping, whereas male students scored higher in humorous coping. So other than those, they also look at the correlation of the spiritual health with the coping scores. So they found that the self-actualization domain of spiritual health was significantly related to the adaptive coping scores and some other coping strategies like turning to religion and humor. And the authors actually propose a model of health balance here. And you'll see that in this diagram, they have included spirituality as a core area for well-being. So in addition to physical, mental, and social well-being, spiritual well-being is highly important. And people sometimes can have adaptive coping, sometimes they can have maladaptive coping strategies. And so a balance is needed to be maintained between the adaptive coping and maladaptive coping. And you will see that there are some common types of coping strategies like acceptance, venting emotions, turning to religion, and humor. So that's a model that the authors had proposed. And the authors also recommended that healthy spiritual practices like meditation would be very important. As all of us know, they would help to relax our mind and help improve our concentration in work. Things like social gatherings could help to exchange ideas and broaden the mind. And certainly spiritually healthy person can actually justify their ideas better and work better. And the authors also emphasize that spiritual health is everlasting throughout life and also influences us to cope with adversities. So they suggest that life skill education program, development of spiritual health, as well as augmentation of adaptive coping skills. Actually, we need to do all those starting from adolescence. Hopefully, they could actually help prevent depression and generalized anxiety disorder. And the authors also suggested looking into inclusion of this in the national mental health program in India. Another similar study in India, also published in 2016, again, look at spirituality as a way of coping from burnout in medical students in the Indira Gandhi Government Medical College in Nagpur. And so in this study, they also used different scales, different questionnaires to measure about burnout as well as spiritual attitude. So these are the two major inventories that they use to measure. So burnout, they use the burnout measure short version. And for spirituality, they use something called the Spiritual Attitude Inventory, SAI, which was something proposed from the United States. It's a 28-item scale by combining 4 validated spirituality scales. These include the Duke Religion Index, which measures religious spiritual practice, the Negative Religious Coping Scale, which would look at the use of religious and spiritual beliefs in coping, the Existential Well-Being Scale, the EWBS, which measures sense of purpose and connections, as well as the Multiple Health Locus of Control Scale, which looks at the sense of hope and control. So the authors look at, first of all, how some of the social demographic variables would correlate with burnout. They found that burnout was actually more in female, actually, in this study as compared to males. So it's a little bit different compared to the previous study that we saw. And they also saw more burnout in the hospitalists. They didn't find major differences in burnout in terms of rural versus urban background. And all the students included in this study, they were from either the upper class or upper middle class, and there were no significant difference between the two groups in terms of the burnout. Interestingly, of the burnout medical students, most were actually in the final year or internship compared to the earlier years, which also would make sense. As people progress in the medical studies, they are also experiencing high stress level. Now, when the authors look at the different scores under the spirituality scales, they found that students with burnout had lower scores compared to students without the burnout on the different domains of the spirituality as measured by the 4 subscales, which is what one would expect as well. And also, they found that the burnout would also lead to lower score in all of the 4 spirituality scales. Or I should say, they are negatively correlated with the 4 spirituality scales. So more the burnout, less the spirituality. And so the authors suggested that it's important to encourage adoption of preventive measures. And being more spiritually inclined has been associated with less burnout. So educators would need new methods to be implemented to facilitate existing spirituality and see how to achieve it further. And the authors also mentioned that in the United States and the UK, there have already been various curriculum included in medical education about competence, communication, and training in spirituality. But in India, it sounds like it's still in a very early stage. And so to all the educators in India, this is another study suggesting that it's important to further develop research and programs in spirituality in medical school. So I've shared with you 2 studies from India. I also want to point out that not only has spirituality been associated with burnout, but there is something called the concept of hidden curriculum, which I'm going to explain further. Hidden curriculum have also often been conceived as a more negative thing in medical education. And in this study done at Harvard Medical School, published in 2015, they try to look at the role of spirituality and religion in addressing hidden curriculum. So hidden curriculum is the process of formation, but largely based in apprenticeship, which instills behaviors, attitudes, and values among trainees in tension with the ideals of the medical profession. So in other words, these are kind of the unspoken things that students or trainees learn from being in medical school or in residency programs. And these hidden curriculum often negatively affect the positive behaviors and attitudes of trainees. And the hidden curriculum often are generated by very deep social structures, some internal to the medical profession, but some external to the medical profession. Some internal social structures would include poor behavioral modeling from practicing physicians. And that poor modeling would lead to devaluing and objectifying patients, and also have rigid hierarchical relationships between health professionals and patients, which would also limit correction of abuses of power. External social structures could be shaped by, especially in the United States, market forces, and the growing medical legal issues and growing bureaucratization of the clinician-patient relationship. And in a certain way, technology might have also contributed to that. So to address the hidden curriculum, it's actually important to have incremental, sometimes maybe just local approaches to try to foster virtues and to pass on to trainees the heart of medicine. So spirituality has been suggested as a critical resource within medical education to address the hidden curriculum. So in this particular study, I won't go into the details because of time, but they had used a qualitative approach, semi-structured one-on-one interviews, as well as focus groups among Harvard Medical School students and residents and faculty members to look at this issue. So I want to draw attention to the results. So they identify three major themes. So number one, religion, spirituality may present unique challenges and benefits in relation to the hidden curriculum. So some of the benefits would include the more religious and spiritual participants, they actually describe less conflicts within the medical team. They describe better work-life balance, and also better coping from patient suffering. And the more religious and spiritual trainees, they would describe using prayer, faith, compassion as means for coping, whereas the non-religious or non-spiritual trainees might use other strategies, you may say, less healthy strategies like compartmentalization or emotional repression to deal with patient suffering. And also, thirdly, the level of spirituality or religiosity may also fluctuate in relation to medical training. In this case, they reported that many trainees actually experience an increase in the religiosity and spirituality during the training. Again, this is, as the authors have mentioned, it's only a very preliminary study, but they have certainly pointed out the important role of spirituality in medical education. So again, I would emphasize looking into that hidden curriculum and how spirituality might address that in the Indian setting. Now, another study, now this is done at Yale University Medical School, published in 2015. I'm going to show you two studies by Professor Doolittle, based at Yale University. The first study looked at burnout and coping strategies and spirituality among interns at Yale. And so basically, they use various validated instruments, including the Maslach burnout inventory, the COPE inventory, as well as the Hatch spiritual involvement and belief scale to measure burnout, coping, and spiritual attitudes. So I'm going to show you some information here. So this is to show that you will see that burnout actually increased significantly among the interns. So when they started off in summer 2009, compared to winter 2010, you will see that there is significantly increase in high emotional exhaustion, as well as high depersonalization, as well as the self-perceptions when the interns were asked, do you consider yourself burnout? You will see a much higher proportion of people have reported that. Now, the other thing is in terms of spirituality, there was no significant differences, but you will see that so I'll draw attention to the lower part of this slide. So among the intern population, where the prevalence of burnout was high, attendance at religious services or private religious practices, actually, they were not found to be significantly associated with burnout. Instead, it's actually the internal and existential qualities of faith, for example, purpose, meaning in time of hardships, they were found to be significant. So what the authors have suggested was that it's actually the more internal, or what they called the internal fluid domain. My life has purpose, my spiritual beliefs continue to evolve, I can find meaning in times of hardship, as well as things like meditative or existential domain. These would be helpful for coping with burnout, whereas the more the external or overt, type of behaviors, like attending religious services, those were actually not helpful for burnout from this study. And so they concluded that the interns who employ specific strategies of acceptance, active coping, and spiritual attitudes had lower level of burnout. But perhaps a bit surprisingly, behaviors like reading outside the field of medicine, regular exercising, and taking time for family actually did not lessen any aspect of burnout in this study. So it's important for program directors and interns to recognize these kind of factors to help mitigate the negative effects of training. Another similar study by the same group, they look at the burnout, coping, and spirituality among the internal medicine resident physicians. So the previous study was looking at interns. Now they are looking at the residents. And long story short, they actually found quite similar results. Certainly they found that burnout was quite prevalent, affecting many residents. And they found a range of emotional and spiritual coping strategies that might be beneficial. In the interest of time, I'm not going to go into details, but just want to bring to your awareness, of these two studies, because the earlier studies I showed you, they talk about spirituality and coping and burnout in medical students. These latest two studies, they talk about the issues in residents. Again, they found that residents who place high priority on healthy relationships, engage in active spiritual life, and practice humility may have important personality traits that protect against burnout. Again, similar to the previous study, they found that no single activity, including exercising, meeting with a mentor, or being involved with a scholarly project, had any protective effect against burnout. Even though the authors hypothesized that extracurricular activities or taking time with family and friends could help to cope during residency, they actually did not find any significant relationships in terms of helping burnout. So again, educators would need to keep these in mind. All these suggest that spirituality might play a very important role in addressing the issue of burnout in medical training. And the authors even suggested that, when residents are being selected for residency programs, the program directors should look into things like emotional maturity, proactive coping, and humility be considered, rather than just academic performance. And the authors also suggested that creative ways to foster emotional health and proactive coping will be very important. The last study I'm going to show you about the role of spirituality on burnout in medical trainees is this study that was actually published just last year. This study actually pertains particularly to Catholic health providers. And they suggested something called the spiritual works of mercy as a tool to prevent burnout in medical trainees. The spiritual works of mercy is a Catholic tradition. So if you look at the middle part of this abstract, an ancient Catholic tradition called the 7 spiritual works of mercy, which consist of the following: counseling the doubtful, instructing the ignorant, admonishing the sinner, comforting the sorrowful, forgiving injuries, bearing wrongs patiently, and praying for the living and the dead. These 7 domains might actually help with coping with burnout. And they are saying that using this as a framework, there are examples how to prevent burnout in medical trainees. For example, encouraging trainees to express doubts or to debrief after difficult and settling cases. And also the academic physicians are providing instruction, feedback, or admonishment, demonstrating forgiveness of errors, and modeling the way in bearing wrongs patiently. And they even mention uplifting the trainees in prayer. Now, they mention specifically that these are strategies for the Catholic healthcare providers and medical trainees. So I mentioned about this study because I understand that there are more than 20 million Catholics in India. So this interesting study might be considered, especially for those Catholic medical trainees and physicians. Now, I would like to go back to my original, I know time is running out, but originally I planned to spend more time talking about how, generally speaking, spiritual and religious competencies are being taught to medical trainees. And teaching spiritual skills in coping with burnout in medical trainees, they are only a small part in this general literature. So more generally, these studies, they are actually looking at how to teach spiritual and religious competencies in medical trainees so that they can address these issues in clinical settings. In the interest of time, I'm just going to point out several major studies that you can actually further look into. So this one, systematic review published in Australia, I think is a very, very good reference. Currently, this article has been accepted for publication in the Internal Medicine Journal. And the authors actually did this systematic review because they wanted to develop a curriculum of teaching spirituality in medical students in Australia. So they were looking at studies focusing on the past 10 years. So from 2010 to 2020, they only look at studies in English. And they found they had screened 342 articles, and they included 17 papers in this review. And they found that the following features have been discussed frequently in the papers published on how to teach religious and spiritual competencies to medical students, like chaplain shadowing, communication skills training, self-reflection, examining evidence, and relationship building. So in this review, they also talk about the concept of entrustable professional activity. I don't know if this concepts are being widely used in India, but in Australia and also in North America and Europe, this is something that's been talked about quite a bit in medical education in the past decade. So basically, an EPA is defined as an essential task of a discipline that an individual can be trusted to perform without supervision in a given clinical situation. Not only will it be observable and accessible, but the related skills will build pertinent competencies for this particular discipline. And so the author suggested that among teaching spiritual competencies, spiritual history taking would be an EPA that would involve key communication skills and strategies to integrate the activity into person-centered and culturally sensitive assessment and care provision. And so these communication skills can actually be taught in role play, in simulated patient encounters, and recorded and coded as observable skills, and can be assessed pre and post training through structured patient assessments. And I want to mention this because for the medical educators among the audience, this is something to keep in mind, when you think about how to actually teach spiritual and religious competencies. I'm not going to go into details here, but the authors have suggested that several specialties, especially primary care or family medicine or general practice, as well as psychiatry and palliative medicine. These are the specialties that most of these studies have been reported in. So maybe these specialties can actually take the lead in co-developing curriculum in teaching spirituality in medicine. Again, I'm just actually skipping these slides because of time. We could discuss further later on, if anyone is interested. But to summarize, in a spirituality curriculum, we can think about having the aims of, fostering whole person care in terms of attitudes, knowledge, and skills, and to reduce barriers to spiritual care. And some key learning objectives could include spiritual history taking, building communication skills, relationship building, self-care. So here, it relates to what we were talking about earlier in my talk, and also understanding the main world belief system. And the core content could include chaplain shadowing, teaching OSCEs, case-based discussions, simulated patients, real patient history taking, self-reflective journaling, small group discussions, and some have even suggested spirituality dinners. The authors argue that all medical students should have a grounding in learning about religion and spirituality during the medical years. And they especially recommend having this training in the clinical years because students would have had more clinical experiences, and so they can actually learn in the clinical settings, and also they can relate the learning to their clinical experience. The author suggested that a short intervention probably would be more feasible in the real world. And indeed, for a lot of these studies published in the literature, most of them were actually short interventions. And even that short intervention could have significant impact on teaching spiritual and religious competencies. And so they mentioned that perhaps integrating at least 2 half-days into the 3rd and 4th year medical school curriculum can be considered. I will also draw attention to the second part of this. They mentioned that students had actually reported that participation in learning about spirituality and religious competencies have actually grown their understanding and willingness to engage with spiritual dimension of patients and the healthcare. And also, when spiritual history taking is formally taught, trainees' confidence in doing that is also increased. And so the authors concluded that when spirituality is included in medical education curriculum, barriers are reduced, skills in history taking is enabled, whole person care is enabled, and medical trainees can be better equipped to understand their own needs for spiritual healthcare, spiritual self-care as well. And so it's important that this be included in the standard medical school curriculum. Another very important study that you should be aware of is this study, Spirituality and Religion in Residence and Interrelationships with Clinical Practice and Residency Training, a Scoping Review that was just published in the BMJ Open a few months ago by a team from Singapore. Again, I don't have time to go into the details. I would ask you to look at this article. This is a very well done article. So they actually focus on residency training, whereas the previous systematic review was mostly looking at medical student education. So in this current review, they look at the extent of attitudes of residents regarding spirituality and religion during residency training, impact on clinical care, as well as psychological well-being of the residents, and how these curriculums have been implemented in residency programs. So they've actually identified 44 studies. Most of these studies were done in family medicine, psychiatry, as well as internal medicine residency programs. But there are also some studies that were reported from pediatrics and surgery and critical care programs. So here are some key findings that they found. So they found that residents held positive attitudes about the role of spirituality and religion and the impact on patient care. Things like better therapeutic relationship, treatment adherence, and coping with illness. The problem is, in many studies, trainees often reported lacking the knowledge and skills to address these issues. Many of these studies also reported better spiritual well-being of residents have been associated with greater sense of work accomplishment and overall self-rated health, as well as decreased burnout and depressive symptoms. The authors also found that these spiritual and religious curriculum, they varied widely in terms of how to deliver. So they can be from standalone workshops all the way to continuous modules across the training years. So in conclusion, the authors had advocated for better engagement of the residents through different pedagogical strategies. So with things like supervision, feedback, reflective practice, and ongoing faculty and peer support. And further studies should identify barriers to having this training, and also the impact of this training on residents and patients over time. I'm going to actually skip over this. This is to talk about what are some barriers to addressing spiritual and religious concerns during clinical encounters. So the most common barrier identified was insufficient time during clinical encounters, but also the fear of offending patients and self-perceived insufficient training and knowledge. Those are also barriers. So again, through these spiritual and religious teaching, hopefully some of these barriers can be addressed. Again, family medicine, psychiatry, internal medicine, some of the lead specialties that can take a leading role in actually developing these curriculum. I'm going to skip over these. So please refer to this paper, which is actually open access for further details. And in this paper, they talk about several easy to use ways to teach spiritual history taking. So the two that I want to highlight, many of you probably would have heard about, is the FICA by Dr. Christina Puchesky in the United States. So FICA, FICA stands for faith or belief, importance and influence, community and address. So that's the acronym for what people can ask in a spiritual history taking. Another commonly used acronym is the HOPE, developed at Brown University by Dr. Anand Daraja, pardon me for my pronunciation, but the HOPE acronym stands for Sources of Hope, meaning comfort, strength, peace, love, and connection, organized religion, personal spirituality and practices, as well as effects on medical care and end-of-life issues. So in these papers, they've given examples of how to actually ask questions pertaining to each of the areas of the hope. So I would recommend that you go to these papers for further details. Some people have been concerned about is it ethical to actually teach spirituality and religious competencies in medical training? And also, is it ethical to actually ask these questions in the medical setting? So this particular paper, they talk about how to actually do it in a rational and ethical approach. I strongly recommend that you take a look at the paper. And in this paper, they actually did a large-scale study, and they found that when patients are facing serious illness and prolonged suffering, they are especially more willing or wanting spirituality and religion to be discussed with them. And they indeed, they want the doctor to understand their beliefs and how that would influence people's coping with being sick. And other than those tools, I also want to mention about this quick paper published in Academic Medicine in 2014. They talk about a novel educational innovation of using an OSCE, not for assessment, but for teaching. So they talk about how to use the OSCE to teach trainees in engaging with patients in talking about religion and spirituality. Again, I don't have time to talk about the details. You can refer to the paper. Lastly, I just want to say that actually in the psychiatry, in the DSM-5, we have something called a cultural formulation interview, which also provides a semi-structured way for psychiatrists to ask about questions relevant to spirituality and religiosity in patients. So there is the core module of the cultural formulation interview. Several questions are pertaining to spirituality and religiosity. But there is also supplementary module 5, which focuses specifically on spirituality, religion, and moral traditions. If you search online, you can obtain the full text of the supplementary module, as well as the core module. Last but not least, the systematic and scoping review that myself and my colleagues had published in Academic Medicine, we were specifically looking at the studies teaching spiritual and religious competencies in psychiatric residency training. So the difference of our study with the BMJ Open study was that we only focus on psychiatric training, but we actually did a quality rating of the studies, whereas the BMJ Open's review did not do a quality assessment of the studies. In any case, I know I'm running out of time, so if you're interested, you can actually go to the website of Academic Medicine. Just want to mention that in the United States, around actually more than 20 years ago, they had actually developed a standard curriculum in teaching religion and spirituality in psychiatry residency programs. And so that's often been referred to the Larson curriculum, looking at the knowledge, skills, and attitudes related to religion and spirituality in mental health. Again, unfortunately, I don't have time to go into the details, but just know that you can refer to the Larson curriculum published in 1996 or 1997. In our study, we found that different residency training programs had actually used a variety of methods, all the way from didactic teaching to case presentations, discussion groups, to more novel methods like literature review, film review, clinical experiences, role playing, or even spirituality dinner. Most of these studies were actually done in the Western world. So definitely more studies would be needed from Asia, for example, or Africa, South America. And a lot of these studies, they are okay in terms of quality, but there was only one randomized control trial published. So certainly we need more of these studies. Generally speaking, we found that these spiritual religious teaching have been well tolerated and appreciated by patients and trainees. And further studies should look into how experiential learning could be incorporated. So in the past hour, I've reviewed the literature on how to use spirituality in helping with burnout and coping, as well as how to teach spiritual and religious competencies among medical trainees. I know, I'm rushing through the studies because there's a lot of information, but, thank you for your attention, and I welcome any questions.
Thanks a lot, Dr. Alan. I think the studies were very, very informative and a lot more to read and understand from them. There are a couple of questions, I'll just pick up one because in the interest of time. What can be done to make spirituality more appealing and effective for millennials?
Sorry, for
millennials.
For millennials. Yeah. Okay. So that's a very good question. I would say for the millennials, technology is very important, and so I think creative use of the technology would be very important. Indeed, recently there have been more and more studies published looking into the use of health technology in delivering mindfulness interventions, whether it's mindfulness stress reduction group or even mindfulness-based stress reduction, mindfulness-based cognitive therapy groups, things like that. So I would think that we need to speak the language of the millennials. The use of health technology would be important. And also, I think from a mental health promotion perspective, the use of social media would also be very important. Hopefully, we can create a culture or promote a culture that use of mindfulness practices is actually very trendy. As you have mentioned, in the old days, people thought that is only people over 60, who will be doing yoga or spirituality. But I think now, at least, in North America, it's become trendy.
Also, I feel that spirituality is not just about meditation. It's also about becoming aware. You can become aware through picking up a dancing hobby, or you can become aware in nature. So I think the millennials have various options which they can do what connects to them to basically connect to their deeper side and become more aware about themselves. So it's a whole lot of things they can explore.
Absolutely.
There's one more last question, and then I think we'll have to call it off. You have mentioned the burnout for medical students in the final year. What coping mechanisms could be introduced as a part of the program, if not in the curriculum?
Sorry, can you repeat the first part of the question?
You have mentioned the burnout for medical students in the final year. What coping mechanisms? Yeah. So what coping mechanisms can be introduced?
Yeah. So I think certainly the formal teaching of some of the coping strategies like mindfulness practice again, and also as you mentioned, self-awareness, actually being in touch, with their own body, being in touch with their own needs, I think is actually very important. But I think it's actually more than what the medical students should be doing or can be doing, because I think the faculty would also need to promote that in the teaching as well as in the clinical interactions with medical students. I think in clinical settings, sometimes some faculty members may interact in a way that may not be promoting well-being, with the trainees. So like what I point out, the hidden curriculum issue. So I think that should be more fully explored in the Indian setting and also in many different settings as well.
Yeah, because in one of the studies you mentioned that US and UK are already putting it in the curriculum, whereas in India it's still lacking. It's quite surprising because India is a spiritual hub, and for thousands of years we've had spiritual teachers here. So I feel it's like quite contradictory.
It's quite interesting. I was a bit surprised as well, when I was reading. Of course, the paper was by an Indian author, and so I would trust, their words. But I absolutely think that there's a lot of potential, just like you said, because India has such a strong tradition in spirituality. I think there's actually a lot of potential for actually integrating spirituality in promoting well-being and preventing burnout.
Yeah, sure. Thanks a lot, Dr. Alan. It was a very interesting session. Lots to learn and lots to read. I've got more. So over to you, Anirudh. Thank you so much.
Thank you, man. A big thank you to Professor Alan Fung for giving us that very, very insightful presentation, which was duly needed, because you see, when it comes to spirituality, when you see something tangible in numbers and how the surveys are done, even that needs to be understood by this generation, which although I'm slightly elder, I'm 40, but the millennials, they're very keen on, okay, what are the numbers? What is the survey? Everything goes into a pizza format for them. What slice of the pie I'm getting. With that being said, ladies and gentlemen, a big thank you to both of you. Now at the time I end the session, a big thank you to MHFI, AIMS and Rahat. That's right, Rahat, which has Mind Specialists and C4MH. It's an online initiative of Rahat. Do find us, and all you have to do is just go hashtag unblocking the power of one, follow us, and that's what life is all about. We heal together. I heal, because that is where we create a universal consciousness of healing. And today was very informative, where we had talks on substance use, a stress management workshop, which was basically intervention of home, building resilience, teaching religions and spiritual competencies, of course, what Professor Alan just enlightened us with, mind, pandemic, and public health. We had another interesting session with. So second day is done, but the third day is there. You see, we believe in Holy Trinity. Once again, it's MHFI, AIMS, and Rahat coming together. So 3 days to banta hai, and that's how we celebrate mental health. You see, mental health is meant all health, and health has heal in it. So to heal together, it is meant for all to be healthy. मेरे ख्याल से मेरी तरफ से भी ज्ञान बहुत ज्यादा हो गया. With that being said, I am ending this session for today, and day 3, which is the culmination tomorrow. Again, we have excellent speakers. It will be a severe loss if you miss them. So I would suggest all you need to do is join us sharp at 10 in the morning till 6:30. We'll be very much tied up with a whole plethora of luminaries. So I'm going home because I need to have my cup of tea now. Gyan bahut ho gaya hai. Now I need to contemplate and heal. Heal the right way that I've been taught. With that being said, love you all. Stay blessed, stay positive, and spread the word. Spread this positivity. See you.